morning, everybody. At the outset, I'd like to thank the organizers for giving us this opportunity. My topic is on dislocated IOL fixation techniques. So I'm going to show you different methods of fixing dislocated IOLs. So you can do it either ab interno or you can do it as a scleral fixated IOL. The case one is a 70-year-old male with history of phaco-foldable done 15 years back at our hospital. Vision was 6/6, but his only complaint was that he had some oscillopsia. That means a shaky vision. And on examination, he had a pseudo-exfoliation present. And also you can see that the IOL is moving in the bag. You can see that's a multi-piece IOL which we used to use, MA60, we used to use long time back. And this case was done 7-8 years back. So we decided to fixate the same IOL and glue it into position. So we are preparing the eye to receive the glued IOL. I'm using a pars plana infusion. Two flaps have been done 180 degrees apart. Chariot's pockets are being created, and now it's for us to lift the IOL. You can see how easily it is coming out. The whole thing can be lifted out so easily because almost all the zonules have gone off, and maybe in another 6 months' time it would have fallen onto the vitreous. So now I'm resting it on top of the iris and trying to remove the capsule around the lens. But it's not possible, so I'm using a vitrector to remove the posterior capsule. There is no vitreous. I'm just using the vitrector only to remove the capsule. And once I've released the lens from the capsular bag, now I can fixate it into the sclera. So now you can see that using the handshake technique, I'm retrieving the one haptic. At the same time holding on to the other haptic, and now the other haptic is also being retrieved. And once you've got both the haptics out, then they can be tucked into the scleral pockets which have been created. Some amount of capsular remnants are there which can be handled with vitrectomy. And in this particular case, we didn't disturb the vitreous at all. So once this is done, we glue the flaps together and the case is completed. This patient had an excellent outcome. The same thing is coming. So this patient had an excellent outcome, as you can see that, when this is the first post-op day, when the eye moves, the lens is very stable. So the next case I'm going to show you is again a very similar situation, 70-year-old male, but this lens was a single piece lens, and this was a dislocated IOL bag complex, and patient also had pseudo-exfoliation. As you can see, this is a bag. You can see that the lens is moving. So
Sujatha, 1 minute. There are some chairs in the front. Can you come over and sit here? Thank you very much.
So the next, this time I decided to go for a Hoffman's pocket and to suture it into the sclera. So just a little bit of diagrammatic representation to make you understand what are Hoffman's pockets. They are actually clear corneal incisions which are made about 300 microns deep, 300 even 400 microns, and then you make a pocket into the sclera without disturbing the conjunctiva. So then once it is done, through the roof of the pocket, you can introduce a needle, 27 gauge needle, which is threaded onto the polypropylene, which can be passed through a side port incision. And you can loop it through the haptic. So this is what I'm going to show you now. So this, once it is looped, then you can bring out the suture from the pocket and tie it. So this is the surgery which I'm going to demonstrate, where you can see that I'm creating the Hoffman's pockets. The Hoffman's pockets, once you've done, you just have to make sure that it is at what width that you have it, so that when you introduce a needle through it, you don't go outside the pocket. So that you have to check it out nicely, and then you make also a side port, and now you are introducing the 27 gauge needle and passing the 10-0 polypropylene underneath the haptic and railroading it into the 27 gauge needle, which is again passed through the roof of the, and now it is coming on top of the haptic. So now you have a loop of suture around the haptic, and you pull it out now, and then you can retrieve the same loop from under the Hoffman's pockets, and you keep it aside. You do the same thing for the other side as well. Now you have Hoffman's pockets on both sides. Now you have got the loop of suture which you have kept. Don't suture it now. And see, again a 26 gauge needle is introduced. You can see that it's going underneath the haptic, and a 10-0 polypropylene is railroaded into it. So you have one loop coming out. Now again, the second loop is going, passing through the paracentesis, and now it's going on top. So now you have a loop which is pulling the haptics. So now once you have centered the haptic, you can pull out the sutures from under the pocket and tie it. Don't tie it too tight on one side, then it can shift totally. So just make sure that it's well centered and then tie it. And once that is done, the procedure is over. You don't have to use glue at all in this case. So this patient is again a patient who had a dislocated IOL. This was a third surgery we're doing on him, because every time he came to someone had done an IOL fixation, again it dislocated. So this time we decided the best method would be for him was to do a glued IOL, and again it's a very similar situation where we have a multi-piece IOL, which is very fortunate, and we could retrieve the haptic from under the flap which has been created. And once it's very important to sever all the capsular remnants, because that could be one of the reasons why it keeps getting pulled down. And now you have retrieved the trailing haptic. You can also see that the rest of the haptic is also being retrieved, and both of them have come out, and they can be tucked into the chariot's pockets. And now the lens is well centered. We have and after that he has not dislocated. So it's very important. One of the most stablest techniques of IOL fixation, I would say, is glued IOL. And Amar is an expert, so he's going to follow me and he's going to show you some fantastic surgeries. But we also have an experience of about from 2007, almost about 17 years, done several cases with excellent results. The last case I'm going to show you is dislocated single piece IOL, where I'm going to use a Gothic suture. It's a very simple technique and it can be done by anybody. So that's the reason why I wanted to show you this. I mean, it's not, I'm creating a flap. You need not create a flap, but I created a flap because I was not very sure I will be able to do it. I may need to exchange the lens. So I created a flap just in case I exchange the lens and do a glued IOL. So this is going to be very similar to the second case where I showed you, where we're going to put a loop of suture around the IOL haptic. So in this case, what I'm doing is I'm putting an AC maintainer. Now I'm introducing a Gothic suture. So these sutures are very strong and they don't disintegrate like the polypropylene sutures. And the first suture is passed under the haptic, and the second suture is now introduced and passed above the haptic. So you get a nice loop around the haptic. The same thing can be done on the other side. Through the paracentesis, you introduce the Gothic suture, which is now passed on top of the haptic. So you make sure there is no twisting of the lens. And then the rest of it is from underneath. So basically on one side you go on top, the other side you go from the bottom. So you get a loop so that without the lens getting twisted. And then again you center the lens, and you can see the lot of capsule remnants is there. So that has to be removed, vitrectomy has to be done. So I've just loosely tied the lens. And what I'm going to do is I'm going to do a vitrectomy to remove all the capsule remnants, and I'm also checking to see if there's any vitreous disturbance. Fortunately, we didn't have any vitreous disturbance in this patient also. You can see there's a large L-shaped spurs. It also has to be removed. These are a little bit difficult to remove. It has to be, anti-vitrectomy has to be used, and all the capsular remnants have been removed, and the suture is tightened. Ideally, it will be better to rotate the suture. In this case, I have not done it. I have a 5-year follow-up, and fortunately for me, nothing has happened, but Gothic sutures are notorious for extruding, so they have to be rotated, and then I've glued it into position. So these are the different methods by which you can manage dislocated IOLs. If you have a single piece lens, then you can use one of these methods, or you can explant them and you can do a glued IOL, or if you have a multi-piece lens, you can glue the same IOL. It all depends upon the surgeon expertise, the type of IOL, and the complexity of the case. But I would strongly recommend, all of you do try it, because it is not as difficult as it looks.
Fantastic. Very nice, Sujatha. Fantastic videos. You have shown the different ways to skin the cat, and over to the master, Dr. Amar Agarwal, who has invented so many things, and one of them is a glued IOL, and we're going to talk about it. And we are doing this course successfully not only in AOS, but also in ESCRS, ASCRS, AO, and I'm very fortunate to have Amar as a faculty in this course as well. Thank you, Amar.
So by the time sir starts, just one quick question. Any reason why you are putting air at the last, ma'am, in all of your cases?
The reason why is because we want to be very dry at that time. When you put the glue, now you have to make sure that the entire area is very dry. You don't want even aqueous to come out because the glue will not work. So that's the reason why. Nowadays we're not putting air. These are some old videos, but because if you put the air, now make sure that it's not wet. If it's wet, the glue will not work. So you have to put the glue and wait for about 30-40 seconds, and it will work wonderfully well.